A North Shore inpatient mental health unit where two people died by suspected suicide within a week of each other was not up to standard, and Waitemata DHB knew it. An independent review into the deaths at He Puna Waiora in 2019 highlights a number of serious concerns, including a strong reliance on managing people with medication rather than therapies, early discharges due to pressure on beds, 6-month wait times for talk therapy in the community, a lack of leadership, burnt-out staff, no effective primary nursing system and unsafe elements in the actual building design, problems that staff knew about prior to the deaths. Whānau interviewed for the report believed their loved ones had experienced neglect, humiliation, stress and a lack of dignity, respect, support and therapy at the hands of the DHB. As well as the 2 inpatient deaths, the report also confirms the deaths of 2 other people by suicide who were also in Waitemata's care, one as an outpatient, the other at a respite facility. Waitemata DHB's Director of Mental Health Services, Wright, explains what he thinks went wrong, but starts with an apology.
So can I just start by saying that we want to publicly apologise to the families because this has been a tragedy and clearly there was some deficits in our care. We've written to the families and we've written them a letter of apology. We also just want to acknowledge that we fully accept the recommendations within the review report. So it's our intention to implement all the recommendations in the review report. And this is the DHB accepts it. I mean, our staff come to work every day and do the best they can within sometimes very difficult circumstances.
Deficits is a bit of a euphemism, isn't it? They're shortcomings and failings, aren't they?
Well, yeah, I mean, you can use shortcomings and failings, deficits. For me, it means the same thing. There was issues in terms of the care that were provided to these 2 young men who are not now there with their families for Christmas.
It was more than the 2 young men in care, though, wasn't it? Because there were 2 other deaths by suicide who may not have been in that unit, but they were under the DHB's care and they too are mentioned in this report.
Yeah, there was 2 suicides within the unit, which were 5 days apart, and there was a suicide of a young man in the community who had been in the unit, I think 2 months previously, and there was a suicide or suspected suicide of a person who was in a respite facility in West Auckland.
So that is, well, those are horrendous outcomes for a service that is supposed to protect and care for some of our most vulnerable.
Yeah, it's certainly 2 inpatient suicides are a very rare occurrence. So it's very rare to have inpatient suicides in an inpatient unit any place in the world, but especially in New Zealand. And bearing in mind that the unit's been open since 2015, thousands of people have gone through the unit, but sadly we have lost 2 people in that unit in May 2019.
What of the shortcomings outlined in this report was the DHB aware of prior to the deaths? Because there's a long list. So which ones did you know about?
Well, I don't know if the DHB knew about all the shortcomings, because obviously the individual adverse event reviews that were undertaken when the suicides took place identified a number of areas that needed to be reviewed and recommendations were made, and we started to work on them straight away. So things like the model of care, for instance, and the model of care in mental health continues to change, as you would expect. So the people we deal with today are not the type of people we dealt with 20 years ago.
But Derek, if we can be specific here, right? So there were faults in the building. The design of the building is not necessarily suitable for the kind of care that you're giving people. Nurses don't have a direct line of sight for at-risk patients. They are in offices that are tucked away from the people that they are caring from. There were problems with the nursing model, and this report specifies that these faults were known by your staff and they requested, assistance around these areas prior to the deaths. So you did explicitly know about some of the shortcomings, didn't you?
Well, we knew that there'd been changes to the building because the original design, and as the report identifies, it was a part of the building that was changed. So, I mean, one of the issues we have is we don't have a standard design for inpatient units in New Zealand.
But if you knew there were shortcomings, why didn't you do more and do it faster?
Well, I guess the DHB thought that we had put in systems and processes that would actually assist. Clearly they didn't, which is why there's further recommendations and further work that needs to be done.
Staff shortages, inexperienced staff, burnt-out staff, lack of leadership, wait times for therapies. Did you know about those things?
Well, staffing is an issue, obviously, and staffing is an issue throughout New Zealand. I mean, we recruit a lot of people from overseas because we don't grow enough mental health nurses in this country, and that's partly about the way mental health nurses are trained. It's very different to the years ago when I trained as a mental health nurse. So recruiting people into inpatient units is always a challenge, and we've certainly been very successful over the last 12 months in recruiting more and more staff into our inpatient services. So, but I mean, although there was issues in terms of recruitment, the rosters were filled. So, and obviously that was filled by the use of casuals and also by the use of overtime. So we didn't have roster gaps.
But the point is, you knew there were issues around staffing.
And we were working hard on these issues around staffing. You can't just, we can't just create staff out of thin air. We actually, a number of the staff that we recruit come from overseas, and that takes time, as well as obviously our homegrown nurses. So we take the new graduates. We have a number of staff and students who come on placement with us, and obviously we recruit into them. We have a new nurse program that we run, so we bring about 20 nurses into that program every year as well. So we're trying really hard to make sure that we've got enough nurses, enough clinical staff to actually continue to provide services.
And I appreciate that you were trying very hard, but was what you did good enough?
Well, clearly in hindsight, no. I mean, at the end of the day, 2 people lost their lives while under our care. I can't walk away from that, Lisa.
In terms of the care people receive at He Puna Waiora, why is there such a heavy reliance on medicating patients?
Well, what you have to remember is that it's a balance. So the people who come into an acute inpatient unit are often very unwell. So medication is often the first line to actually calm the person, to get to the point where you can actually start to do more of the psychosocial services. A lot of the psychosocial work is actually done in the community. And with the changes in mental health, with Hera or Oranga and the move to primary mental health, secondary services will actually do less work than we'll do in primary mental health. And that's where you can do a lot of the psychosocial. So getting people early in their illness, not late in their illness. But
your own staff indicated to the people who compiled this report that they felt there was an over-reliance on medicating patients. I'm wondering, was that basically a form, effectively chemical restraint, isn't it?
No, it's not, and I think we've got good evidence to show that. We've got the lowest seclusion rate in the country, and there's been a programme that's been run by the Health Quality and Safety Commission for the last 5 years. And what that's shown is that our staff actually work actively with the clients to make sure that we can deal with situations where a restraint or an incident may occur, and that's not happening. And there's no evidence that to do that they're using more medication. So
that reliance, sorry to interrupt, but was that reliance in any way because you don't have the therapists available to work with people in these inpatient settings, or as many of them as you need?
Well, we'd always like to have more therapists. We've actually increased the number of psychologists. We've also increased allied health assistants at the weekend so that we can run extra programs at the weekends, because obviously when you're in an inpatient unit, one of the issues is actually making sure that there's enough activities to keep you stimulated as well. And in some situations that probably wasn't happening as well as it could have because of not that the positions weren't there, but some of the positions weren't filled.
Which brings me back to my original question, Derek. Is the heavy reliance on medicating patients because you did not have those other resources, access to talk therapists and other specialists, and staff available to assist with activities that would stimulate the people in that environment and help them recover?
It's a balance. I mean, medication is always going to be
Did you have the balance wrong?
Well, we may well have had the balance wrong in hindsight, but at the time we actually believed that the balance was about right. And obviously...
But how can you say that when your staff have told investigators that they feel there was an over-reliance? They are indicating, the people at the coalface are indicating that you had the balance wrong, aren't they?
Yeah, and I accept that that's the view that's come back from our staff, and that's why we're trying to change the balance to ensure, and we've already put in more programmes, and we've put in more psychologists, and we're actually just out to recruit another 2 psychologists for the units as well. So we're trying to, and again, it's not that easy to recruit psychologists because obviously a psychologist gets paid a hell of a lot more if you go and work in corrections than you do in a DHB.
The 2 people who died by suicide, who were not in He Puna Waiora, but were under the DHB's care at the time of their deaths, did they have a safety plan in place?
Yes, they would have. They would have had a crisis plan and a recovery plan in place.
Are you sure about that?
Well, clearly they didn't work because we've got 2 people who took their own life. Well, we suspect it took their own life. Only the coroner can actually rule, but that's certainly what it looks like. But there was plans in place. Were they followed? I can't say.
And you are sure that at the time of their release, a plan was in place at that point in time, not later?
Well, one of them had been in the community for about a month and was being regularly followed up. So they would have had a plan in place, and they were being regularly seen by their community worker, their community nurse. The other person was in a respite facility.
So did they have access, the person who was in the community, access to talk therapy, or were they on waiting lists?
The person in the community, as far as I'm aware, if we're talking about the same person, they were using a private psychologist. Right,
so they couldn't get access to publicly funded services?
Well, you don't need to double up. If you've already got a therapist, then it doesn't make sense to then change if you're happy with the therapist that you've got.
And that was Waitemata DHB's Director of Mental Health Services, Derek Wright.